It's the afternoon, 2 o'clock on Wednesday, April 30th. We're continuing markup on S-126. We're in, if I recall, section 3, I think 3A.
Dan Kirby from the Office of Legislative Counsel. I will put this on the screen. Right. You can see the language. So we were in the section that was creating the reference-based pricing provisions. We looked a little bit at 3A, that the board would begin implementing reference-based pricing by establishing the amounts, and I'll be flipping this around, so it will be provider charges as soon as practicable, but not later than hospital fiscal year 2027. It also requires the board to implement reference-based pricing in a way that does not allow for balance billing, which is hospitals charging or collecting from patients any amount in excess of the reference-based amount established by the board for the item provided or service delivered.
Actually, is that really necessary?
Which that
Okay, so if the board sets prices,
if we're doing it as provider charges,
yeah. If we're doing it as provider charges, then you can only, the charge can only be what the charge is. If there's a contract with the payer, the contracted amount, which will not exceed the
Right.
charge amount, and they can't balance bill anyways. But why do we need this in here? Because if it's a self-pay, it's not as though a hospital could charge more than the charge amount.
right? No, I think if we're flipping it, we may not need the balance billing section. I'm looking to other crowd advocate who agrees. So yeah, I think that's a good call. We can.
Yeah, go ahead.
Like Fisher. Where is balance billing allowed today?
I don't understand what balance billing is.
I mean, it's not allowed through a commercial agreement. It's not allowed in Medicaid, it's not allowed in Medicare.
Right. I don't know if it's allowed in under ERISA for self-funded. I don't know. No, that's. I don't know. This was a concern that I know had been raised in the Senate committee, so we put something in. But I think it becomes even less of an issue.
If balance billing is allowed somewhere, I can imagine needing this section, but I can't dream that.
Right. But I don't know that it fits as much in the construct of a maximum or, the amount that the provider shall charge.
Yeah, because you can't charge different rates to different people. I mean, it's not like you can say, I'm going to charge this person $100 and I'm going to charge this person $200.
Under this construct.
Under any construct, your charge amount has to be the same for everyone. The contracted rate for a payer may be different. And the amounts that Medicare will pay and Medicaid will pay are going to be different. But you can't change your charge amount.
I don't know if that's true, or if that's true for all professions and for professions that are not paid through insurance. So I don't know the answer to that.
Have a network. Except, at least here in Vermont, all hospitals are in network. We're starting, but.
But even if you're out of a network, you can't change your price, your set price for something. I don't know, maybe our hospital.
And I'm looking to FQHCs because I think there's a sliding scale at the end. Some facilities, and I think in some places there's a sliding scale, so the amount you charge does change.
But doesn't the starting charge all start the same?
With Mary Kate, Vice Primary Care Association, with the sliding fee scales,
if you are, we have to offer a sliding fee to anyone under 200% of the property level. And then the difference between what that cost is and what we charge the patient is made up for with our 330 grant funding or outside funding.
Yeah, but you would never say, I'm gonna bill Blue Cross Blue Shield for this exact same service, $200, and I'm gonna bill $150 to this person. I mean, your sliding fee scale is based upon the actual fee for that service. And then you go down from it.
Yeah, on the commercial side, you can apply the sliding fee to if they have high deductibles. Anything that they would owe through the high deductibles. And to the commercial, like MVP provides like a PPS encounter rate. Blue Cross Blue Shield is the community fee schedule, so, but it's not, but we follow that fee schedule.
Devin?
Devin Green from Buzz, I think this was put in here because in other states, it wasn't done. The rate setting is the insurers and balance billing could happen that way if you don't have prohibitions.
Yeah. But if you're setting it for the rates, then you can't
This
have,
is probably just taken from other states' language.
Okay, so I'm happy to.
So what harm is it by being there?
I think
It
it,
might
well,
be a protection somewhere down the road.
it confuses it, doesn't it?
Maybe.
I don't know. I don't know if there's any harm in having it. I don't know that it's necessary, but I also don't know that it does any harm.
Brian?
If you don't know right now, it's okay, but I am curious what law or rule or custom guides that, because I know as a healthcare provider, I was taught that I had to bill the insurance companies the same charged amount, and then they pay me the contracted amount, and on the explanation of benefits, it says you're being paid less than your charge because this is your contracted amount. And when I do sliding scale with people, I say $20 up to the charge amount. And I always say to them, no one ever pays that though. Every insurance company like pays less than that charge amount, but that's what I think I'm worth. But I am unaware of what rule, law, or what guided that practice that I was taught. So do you know, is it in Vermont law or federal law that we have to do that? Or is that just a practice? And if no one knows right now, it's okay, but
I believe surprise billing is banned in Rule 0903 over at the Department of Financial Regulation. And then there's also now federal surprise billing legislation. So those two pieces of that.
also,
Formally.
Formally,
So-
0903.
so surprise billing would mean if you vary your charge between patients.
No, it's if you bill the patient for something that the insurer didn't pay for.
I mean, I think there's a potential for discrimination if you change what you're, if you don't have some sort of standard practice and you're just choosing who you're charging what amount for without having a clear justification, but it may be more of a professional ethical guideline than a requirement as far as the charges.
And that's what I'm getting at. So I'm not sure what the root of it is because it's just what we do. And it's not really surprise billing. It's like, and it doesn't matter that much.
No, I think
Yeah.
Sarah's talking about something sort of more in the balance billing
Yeah,
version of the patient getting surprised by thinking they had paid the full amount that they were being required to pay directly or through their insurance was being covered, and instead getting a surprise bill for something that wasn't covered.
whatever the case may be, I just asked because I was curious what the root of the practice was. It's not, because it informs this, but it sounds like people aren't gonna do this.
If it doesn't hurt anything, I would say we should keep it in there, but I think the fact that we're moving it away from insurance payments to provider charges, I don't think it's necessary.
I would feel better keeping it in there. I agree with you, but
Okay. If
It's
it,
like belts and suspenders. It's like a protection, even though.
all right, I just didn't want to confuse it as to, I as to what our intention is, that we're moving it away from one to the other. I didn't want that to be a confusing factor.
Okay, subdivision C.
Can I?
Yep.
Yeah, of course, Leslie. I'm sorry, we didn't talk about the date, and there was a date, hospital fiscal year 2027. And if I remember right, Green Mountain Care Board was sort of thinking that that was a problem.
Where are we?
14, and 3A.
What page?
Oh, the same page 7.
Page 7. Bunch of stuff.
Isn't this the same as it was in section 2?
Yeah, I guess what I heard, I mean, I didn't hear, it was not sure how long it would take to implement, report on progress as we go along, but thought that was gonna be, a challenge, but maybe that changed.
I haven't received comment from the board yet.
Did we early on? I don't,
What's that?
did we receive anything early on?
Not that I recall. I'm,
They were looking at hospital fiscal year 26, 27, and wondering if they could, but we could just verify it, maybe I was confused.
that they wanted to move it up or move it back.
Just remove it as a date.
Remove it at the
Remove
date?
date is what I wrote down, but maybe I misunderstood it. Yeah. So, never mind.
You know, I do recall that. And, you know, what we talked about at the beginning of the day. I think all of us, or some of us, had a theme of accountability and ensuring that these things happen. And I'm inclined to leave a date.
Reasonable, except, yeah, fine, totally, unless it's not doable, and we end up tripping over ourselves in an unrealistic way, but no worries. That's just what I heard.
I do recall that in the Senate, there was some, tension between the board wanting to kind of take time and figure out how they wanted to approach it, and the Senate being quite anxious to see this begin. So I think this is the somewhat of a compromise you're seeing here. May not have made everybody happy.
And if we give them the ability to revise within their hospital budget process each and every year, it can be an iterative process. I mean, just because, maybe it's not perfect in fiscal year 2027. That doesn't mean they stop working on it. They can keep working on it.
I think maybe they were worried, I shouldn't speak for them, obviously, about how long it would take to get through rules, et cetera. So that was a concern.
And we can always come back and change it.
Yeah, totally. That's just what I had heard.
Yeah, you can change it. So
Okay.
let's leave it for now.
Subdivision C has the board, in collaboration with the Department of Financial Regulation, monitor the implementation of reference-based pricing to ensure that any decreased prices paid to hospitals result in commensurate decreases in health insurance premiums. The board posted its findings about the alignment between price decreases and premium decreases annually on its website.
And we can talk about this. I don't want to stop our movement here. Talk to this at the end when we have a full, somewhat final bill in front of us, but I don't think this should be just about reference-based pricing. I think it should be information as a whole. I just want to put a flag there that we'll like to come back to that eventually.
The part about the DFR.
Yeah. A part about
The premium decreases.
seeing the connection between changes that are happening in our system and premium decreases.
Section C.
Let me see. All right, on page 8, Number 4 requires the board to identify factors that would necessitate terminating the use of reference-based pricing in one or more hospitals, such as a reduction in access to or quality of care.
Um. Is that a little broad? I'm just thinking, you know, if they use reference-based pricing and a hospital reduces access to a type of care that is not part of the statewide healthcare delivery plan, would that then say that the board would necessitate terminating reference-based pricing? I think it's to my point of, this isn't going to be easy and it's not necessarily going to be pretty. Do we want to just say, I mean, could it be like a depreciable reduction or some sort of
Significant reduction.
significant or a significant quality of care? I mean, what if quality of care was fantastic and it slips a teeny tiny bit? Does that mean that they just throw it all away?
This is just giving examples. So such as is just giving examples, but you could certainly change the language or, remove the provision.
And just not have the example attached to it.
Yep. You could
Like it
do
could
that.
have period after hospitals and say just let us know what would necessitate it without giving any example.
Okay.
I'm just saying that would simplify it, and also broaden it in a sense, because it's like not implying that that's the only thing.
We're done here.
Leaving it up to them on what factors it
Yeah,
would happen? What does everybody think about that?
Do we even? I mean, it doesn't say that it doesn't give them authority unless they already have it to terminate reference-based pricing. It just says to identify factors and to what. And do they already have the authority? They need to?
I think in here, we're telling them that they need to. In the whole bill. So do we need to give them an out?
I think this is a concern from the hospitals, that there be clear expression that if it's not working, it should be terminated. Is that, I don't know if you want to hear from Devin on that.
Woody?
Other than, I think we could keep terminating, but it's been suggested to add or modify.
Yeah,
More modified?
Or modify.
yeah, I have that too.
About the board shall identify factors that necessitate terminating or modifying the use of reference-based pricing in one or more hospitals, period.
yeah.
Leslie?
I'm just, yeah, I mean, I have that same note, but I'm just struggling with correlation and causation, and how are we gonna know that it's reference-based pricing that's causing the problem? And it seems like a mess to me, that whole thing.
Which is why I don't think we should have in there examples.
Yeah, or I'm not even sure if we should have it at all.
I don't want to complicate it too much, but that made me think like, I think it should be there because if they want to terminate it, there should be accountability about why. And if there, but I'm wondering, and there may be language somewhere else in the bill that does this already, but I'm wondering if we got rid of the example and put something like, and propose alternative methods of cost control or something to, you know what I mean? So if they're going to terminate it, what are they going to do instead? Something like that. And if it's not already in there, if it's already in the bill somewhere else, then forget it. It just came to mind when I was thinking about if they felt like they had to terminate it in one or more hospitals, I'd still want them to look at how to save money. Because if they just say, we're just going to terminate this and go back to how we were doing it, I doubt they would do that, but it wouldn't be good.
if I may.
Yeah, can,
Of course,
Did you say adjust or modify?
I think adjust and modify are kind of the same
Yeah.
thing.
I thought we said terminate and modify.
Well, it's on the table.
Leslie?
but there's no real time frame. I mean, how does it get decided? Is it after a year? Is it after 2 years? I mean, I have to have some kind of faith in the board. Maybe she has her hand up behind me, but
No, I think we're just giving them an out if it's a debacle.
Yeah. And making them say,
Kevin,
wow,
would you like to?
And agreement from Buzz, I think what we were trying to get at is learning from One Care experience and saying, let's set up the sort of thresholds now of where we are feeling like this is failing and have a get out option now, and set that ahead of time. That's what we're looking for. Or modify.
Would you be okay with removing the whole reduction in access or quality of care?
I mean, I think access and quality of care is important, so no, I would not be okay with that.
But what about the correlation?
Having it correlate to that.
well, the causation is a correlation.
Is it causation or correlation?
Yeah. I don't know. So basically, it would just be pre-master board setup factors of when we know this is failing, so that we know if we get there.
They can identify factors.
I think it's important for our access and quality of care to be part of those factors. Yeah.
Can I give like an extreme example? So let's say a hospital is put on reference-based pricing. Their revenue being generated is down. And they decide, like I said, I'm just giving an extreme example. They decide we're going to take the resources we have and we're going to fire all of our specialists and we're going to give ourselves big bonuses. Access to care would be affected. But that would be a decision that the hospital made. So that's what I'm talking about is, you know, is that what causes it? Or is it the decisions that maybe the hospital made with the resources that they had that led to that? And that if their decisions had been different, it would not have led to that.
So.
I guess an extreme example, because I don't think that would ever happen,
I
but
hear you on the extreme example, and I see what you're getting at. I think there could be a variety of factors, and I would like quality and access to healthcare to be involved in the factors or in the decision-making process. However, the Green Mountain Care Board gets to it. They can figure out a threshold that takes that into account. But quality and access to patient care are important factors to keep in mind when it comes to things like cutting costs.
do you think that they won't take those into consideration?
I think it doesn't hurt to keep them in as factors.
Well, we have just such as, so it's just an example, right?
Right, do you want a modifier on reduction, like significant or? I mean, these are factors that would necessitate terminating the use of reference-based pricing. So if it's not related to reference-based pricing, having a reduction in access or quality would seem like an odd reason to terminate reference-based pricing if it wasn't the cause.
Lori, I
think with a lot of this stuff, so causation or like connecting it to one thing is going to be difficult. And at the same time, I do feel like for accountability purposes, they should be able to lay out ahead of time some factors that would be like, okay, it's not working, because if they don't, how's it not working? So I'd like to see it in here, and I think maybe add significant, but it's just, I think we should.
So would that be identified in rule?
because this is, they have to identify these factors long before anything bad happens.
It's before, while they set it up.
Yeah, while they set it up.
Yeah.
Is there another modifier? Yeah,
Could we tie it, maybe we don't have this anywhere, to the, when's the state healthcare delivery plan gonna be?
May 29.
I forget that.
Unless you make changes.
right. Once we make changes.
Right, so, but tie it to something like, what's the stated goals of the state? That might be too broad, but anyway, I think we should keep it in.
Or adherence to the statewide healthcare delivery plan.
These are factors that would necessitate terminating using reference-based pricing. So I think
Is there a word between nothing and significant?
measurable, noticeable, I don't know.
And when you do that though,
I didn't measure.
you have to define it. And the way it is now, they set up this list and that's it. If we start putting in words like we were just talking about, you're gonna have, someone's gonna say, well, what's that mean? You're gonna have to define it. You don't have to define anything here.
Right, but I think they should have to define it. I like measurable.
Yeah, I like that.
Yeah, I
Like
like
what?
measurable.
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 So like they are gonna put out factors that will have a measurable, such as a measurable reduction in access or quality of care, like that, we have to be able to measure it.
Yeah.
That's the whole point.
So the word measurable goes before factors.
No,
Identify
reduction.
measurable factors.
Reduction.
No, reduction, such as a measurable reduction in access to
Yeah.
quality of care.
But wouldn't we want the board to identify measurable factors right up front? Because it may go way beyond those two.
So, well, Laura, are you saying the board shall identify measurable factors?
No.
No, that's what I think
That's-
you should say. That's just me.
I think the board should identify factors that would necessitate terminating the use of reference-based pricing. And we are giving an example such as a measurable reduction in access or.
Leaving that in
Yeah,
and
we're,
adding the word measurable.
we're putting measurable in front of
Leslie
reduction.
has a different.
I
like that.
yeah, but how about identify measurable outcomes?
Mm,
Well, I'm not sure how, I mean,
Remember, this is just a such as. It's not saying that they can't identify other things. It's not that we're giving them an example of what we're kind of talking about here.
I see it. It's fine.
I mean, I didn't like putting in any of it, but I'm willing to keep, I'm willing to, but measurable, I like that. I like that. Yeah, Woody.
Yeah, but
Should we have something else in there as well where the board will have to report back to our committees?
There's
Is there something?
There's so much reporting.
There's so much reporting.
No, but I mean, it's something like this, if you're gonna terminate reference-based pricing.
Well, they're gonna be reporting to you annually on the use of reference-based pricing,
I'd
so.
like, if all of a sudden, hospital's losing money and it's going under or what have you. I don't wanna have to wait a year to know about this. I wanna know about it almost immediately, where if you're going to terminate. It's a problem.
This is their rulemaking. So this is the rules that they need to take into account when they're developing reference-based.
You'd rather learn about it now or wait for a year before, wouldn't hear it for a year.
no, they're doing quarterly reports.
Right, I think you should hold that to a day.
Yes, so we get to the reporting, because there's a lot in the reporting section.
All right, now we're getting to, something you've heard a lot about. This is currently has the Agency of Human Services in consultation with the Green Mountain Care Board. Allows the agency may implement reference-based pricing for services delivered outside a hospital, such as primary care services, and may increase or decrease the percentage of Medicare or another benchmark as appropriate, first to enhance access to primary care and later for alignment with the statewide healthcare delivery plan once established.
So we heard a lot about this. I got a lot of notes all over mine.
Great.
The one thing, again, and this goes back to why I can't figure out why AHS would be setting prices for anything, any other entity that doesn't have to do with Medicaid.
My recollection is that the board didn't have any expertise in non-hospital rate setting, or, budgeting. And that the Agency of Human Services had experience implementing reference-based pricing for Medicaid. And so could use that experience more broadly. I think it had originally had the Green Mountain Care Board, and then people said, no, it shouldn't be the Green Mountain Care Board. It should be AHS. So it's AHS. I don't remember if anybody else who was in the room has more detail. I don't remember. Because I think I've said this, a lot of this came together very late.
Brian and Marian, I have a question.
So question and a comment. The question is, it's like a clarifying question. AHS currently uses reference-based pricing for healthcare providers that are not at hospitals. But they don't do it for hospitals.
Yeah, for state Medicaid plan.
Yes, for Medicaid, they don't do it for the hospitals, or they do? They do. Okay, well, here's why I'm asking, because if AHS is currently doing it for hospitals and other providers for Medicaid, and we talked about needing more partnership, why would we not just say that the Green Mountain Care Board and AHS together are just going to do it for everyone?
There's been a lot of pushback on trying to not have, on setting up anything that doesn't clearly identify who is in charge.
I get it. So like there has to be ultimately one organization, person, or agency who's responsible.
Yeah.
Okay. That's so Western.
Sorry.
So going back to my comments earlier in the day when I was on Zoom about, yes, wanting to have one leader in this process, I would switch and say the Green Mountain Care Board in consultation with the Agency of Human Services. So keep the Green Mountain Care Board, keep their role in setting reference-based pricing, but they, like we mentioned earlier, have access to the expertise of AHS.
Oh, I'm sorry.
Excuse me. The Green Mountain Care Board is not providing the service.
Not providing what service?
But neither is AHS.
I thought they were providing the service to Medicaid patients.
To Medicaid.
Yeah.
I mean, there are.
What service does Green Mountain Care Board provide?
They don't.
So
I mean-
all they're gonna do is the reference-based pricing, right?
Well, okay, so here, maybe my question is, which is why I'm confused. So currently, the Green Mountain Care Board already has the authority to do all of this.
Yes, the Green Mountain Care Board has the authority that has never been implemented
Yes.
to set rates that providers can charge.
Yes. So we're tasking the Green Mountain Care Board with setting up reference-based pricing for services delivered inside a hospital. That's what all of section 2 and 3 does. And then we come to this and we're now saying Green Mountain Care Board we don't want you to do reference-based pricing for services outside of a hospital. We want AHS that they, first of all, we're saying that they may implement. What motivation? I'm trying to figure out what motivation AHS would even have in wanting to implement reference-based pricing for services delivered outside of a hospital. Because they'd have no motivation. The only party that would actually have motivation to do it would be the Green Mountain Care Board, because they're trying to right-size the system using reference-based pricing inside the hospital. They're the ones that would want the tool and the lever, wouldn't they, to do it outside of a hospital setting so that they can keep all aligned in the statewide healthcare delivery plan? Okay, so Mike? And I see you, Jessa.
I think, Medicaid agency has a whole lot of experience of setting reimbursement rates, I'm gonna call it. Anybody can do the math to figure out what percentage of Medicare it is, but it is reimbursement rates for providers for Medicaid. No experience in setting reimbursement rates for commercial, none.
Mhm.
The Green Mountain Care Board is tasked with this task of setting reimbursement rates for commercial, now hospitals. I'm trying not to use the words reference-based pricing because I think it's all the same thing. Linked to the impact on consumers in commercial, in insurance rates. Understanding both sides of the coin of that equation and living with the consequences of both sides. So it makes absolutely no sense to me to take some part of commercial out of the Green Mountain Care Board's role and still, like, it's not small, it could be real significant. So, I mean, our suggestion was to just cut this section. To the extent that you want to leave the section, as I agree with Representative Cordes, that, I mean, they already have the authority to do it. But if you're gonna leave it in, I think it's really important that it be the Green Mountain Care Board who's tasked with this. Communicate and understand, learn from the agency, I don't care. But I think it's their job.
Because they're trying to control the rates of commercial insurance. And we're taking 40% of the services that commercial pays for. I think it's 40, I don't know, 60, 40. We're taking 40% of that lever away from the Green Mountain Care Board and giving it to AHS, who may or may not, and they have, again, what motivation does AHS have? Because they're not tasked with controlling commercial insurance rates.
And
When I say rates, I mean like what rate payers pay.
I haven't heard too many providers be all that happy with the reimbursement rates in Medicaid.
You want AHS. Jessa, do you want to say something? And then I'm gonna make a suggestion.
Sorry, I just wanted to clarify a little bit, I think where this language came, or why the language switched, was that there was a lot of concerns from a range of provider types that are largely paid by Medicaid, whether they were in or out of this section. It wasn't entirely clear. It was only limited to commercial rates. So there were some providers who are largely Medicaid funded in the Senate who said, we don't want Green Mountain Care Board setting our Medicaid rates, basically, or our payment rates. Green Mountain Care Board doesn't have experience with paying us. So I think that was the fear that led to sort of a last minute switch of, oh, maybe this should be AHS. I think the providers are really requesting clarity. What rates are you even talking about? What provider types are you talking about? Are we even ready to move beyond hospitals if we haven't even tried in hospitals yet? So I think there would be either comfort, as healthcare advocate said, of removing this section entirely, or being much more specific in terms of which provider types and rates it's referring to.
Yeah, and I could just add on, absolutely no sense to have a concept of the Green Mountain Care Board setting a Medicaid rate. No sense at all, like, and equally no sense in the other.
Is there some way, I'm gonna make a suggestion. Is there some way that we could change this to say that the Green Mountain Care Board, in consultation, I don't know, with the expertise of AHS, that they may, if needed, to, in their insurance rate review, they have the authority to do reference-based pricing for commercial payers across the system as a whole instead of it on an outpatient basis. I mean, that was horrible language. Please don't write that in, but
Well, I'm trying to follow the concept. I mean, if we're doing it on what the provider can charge, then doing it through health insurance rate review doesn't work. I mean, my recollection of the rationale behind this section, which, I was just pulling up, this was from the day before crossover, is where it switched. You can see my markup, from the board in consultation with the Blueprint and other state agencies shall to the Agency of Human Services in consultation with the board may. But my recollection of the rationale for this was really trying to get largely at what you've been talking about around incentivizing primary care and having a higher reference-based price, reference-based reimbursement amount for primary care and using that as a lever to try to increase the types of care you want delivered and decrease the types of care you don't want delivered.
so can we change it to more back to where it was, which is the board may, in their endeavor to,
I think you could have it as part of their building out their rate setting authority.
the rate setting and put it in there strictly that, they may set reference-based pricing with the goals of the statewide healthcare delivery plan for commercial, for providers in the commercial space, or the rates that providers can charge in an outpatient setting.
I think, this second, I think a lot of that is without this had been focused on commercial. And so it doesn't specify it. I think it makes sense to specify. But if you switch these two, I think it largely talks about increasing or decreasing the percentage. It talks about primary care, increasing or decreasing the percentage as appropriate, first to enhance access to primary care and later for alignment with the statewide healthcare delivery plan. So other than who's leading it, I'm not sure, and specifying commercial insurance, I'm not sure it's all that different from what's already here.
Right. Mary Kate, do you want to?
Yeah, I think Mary Kay Bowman by State Primary Care. I want to be careful coming from the FQHC, so we do have federal requirements around what our minimum reimbursement rates need to be, whether it's Medicaid through BIPA or commercial rates through the Affordable Care Act. I and our members would have concerns to give the board regulatory authority to set what we can charge versus using their commercial rate setting authority to set a minimum payment to primary care providers.
I think you lost me on that last sentence.
So not regulating what FQHCs charge. I see that potentially as like a max that we could charge, which we don't think this committee, right? Hearing what you guys are saying, I don't think that's what you're looking for. You want more investment in primary care. But what is the minimum that a payer pays to primary care?
So to sort of re-put this concept that we're going to be changing for the hospitals of setting the amount that health insurers shall pay, or minimum amount health insurers shall pay, however the committee would want to do. Is that what your suggestion is?
What AHS is, because they're setting the rates for Medicaid, the payer. They're not setting rates for what the provider charges. So we'd be looking for parallel language for regulating the reimbursement regulating the payer and the reimbursement they give.
So we're changing the whole entire one or section 2 and 3 to be specific upon what the payer can charge. And now in this one section, when it comes to not in a hospital, we're changing it to what a insurer may reimburse.
I think that's what we're hearing.
Anyone have thoughts on this, Topper? Did you have your hand up?
I did, but I was on something else in the sense.
I know.
Sarah Teach out with Blue Cross Blue Shield of Vermont. I think you're moving away from the Agency of Human Services being the lead. Blue Cross and Blue Shield of Vermont's concern is our solvency. It's leading up who decides how much we pay for non-hospital services, which could be very significant, hospital, and then we would have this new Agency of Human Services deciding how much we pay out that knows nothing about our solvency, our rates, our, anything about that. That's not their area of jurisdiction.
Yep. Which, I think that's my concern.
You would support transpositioning the two agencies in the language,
If you want to keep it in, yes.
Okay.
Thank you.
transposing.
I would support what Mary Kate just said about having this be regulating the rates paid, not the amounts charged. I think that's more consistent with the Green Mountain Care Board's general authority anyway to do rate setting, and also a lot of primary care providers, not just FQHCs, but independent practices are not regulated by the board directly. So I think that would be a complicated kind of new regulatory approach as opposed to rates on the payers. So supporting the direction the committee was.
Is anyone vehemently opposed to any of that?
I like that. That it's, so what, just to be, what I heard you say is that they will regulate, what I'm trying to remember the terminology exactly when we bill, like there's the charged amount and then there's the contracted amount. They would regulate the contracted amounts, but not the amount we charge. So all these providers aren't having to then know that.
Yep.
They just know what they're gonna get. Okay, yes, that makes sense. And that's okay with the insurance company?
No, Topper?
So does that mean if I'm the patient that, the person who's providing the service charges $10. The insurer will only pay $5. Does the patient have to pay the other $5?
No. That's balance billing.
Balance billing piece we were talking about.
And if your provider has contract with that payer, no, that provider cannot charge you that $5.
I can also pull out the balance billing piece and make it more standalone in this section, so it's not specific to the hospitals and applies to.
Yeah, because we're flipping it to, since we're flipping it to what the insurer can pay, not what the provider can charge, then maybe we need the balance billing piece in this piece.
Right, but I think it makes the most sense to have it sort of stand by itself in this area, so that it applies to both scenarios. Benefits may not be strictly needed in the payer charge.
Does anyone have really, really strong preferences to keep it within the Agency of Human Services?
Yeah.
Okay, I just feel like,
No.
I just feel like because the Green Mountain Care Board's task is insurers' solvency and insurance. Well, you're right, I'm sorry, it's CFR, that it's, that it's tasked with insurance rate review, that it should be up to them. And remember, there's a may in here. We're not telling them they have to. But if they need this as a tool. Okay,
If it's a may, my question is, do we really need it?
well, frankly, I don't think that they need it now. They can already do it now.
Right, you can have it in as a may, and if it, time goes on and it doesn't happen and you want it to, you can make it a shall. I think this at least allows you to tell them, tell the various players who you expect to take responsibility in this area.
Lori, did you have a? I'm trying to read, I'm trying to read people's eyes at this point.
I'm fine.
Okay.
Good luck with that.
All right. So we'll make changes around that. Okay,
Hospitals?
hospitals.
Section 4.
We're on section 4.
All right, section 4 is the first of the two sections on hospital budgets and hospital budget review. Section 4 is on the hospital side and what hospitals must file. In this part, what hospitals must file with the board. And this adds some new requirements. So file with the board information on the number of employees of the hospital whose duties are primarily administrative in nature as defined by the board, and the number of employees whose duties primarily involve delivering healthcare services directly to hospital patients. Information regarding base salaries and total compensation for the hospital's executive and clinical leadership and for its employees who deliver healthcare services directly to hospital patients. Proposals for ways in which the hospital can support community-based, independent, and non-hospital providers, including mental health and substance use disorder treatment providers, primary care providers, long-term care providers, and physical therapists, services provided through the Blueprint, Choices for Care, and SASH, investments in the healthcare workforce, and other non-hospital aspects of Vermont's health and human services systems that affect population outcomes, including the social drivers of health. And remembering 10.
Do we want to stop? I have a lot of notes in.
Okay.
In this
already.
Can I ask a question?
Sure.
Jen first. Do you remember what the point of was to having this in here from the Senate's perspective?
No, I mean, I think there were a couple of, for 7 and 8, I think there were a couple of, there's a bill in the Senate and similar bills in the House that were looking for some of this information. And in number 9, it had started as the board in its budget orders, telling hospitals, I think, or providing or suggesting or requiring ways that hospitals could support these other provider types. And the board did not, I think the board did not want to have the responsibility for coming up with what that looked like and wanted the hospitals to propose it instead.
So first in 7, I have a lot of notes around, first of all, what is administrative? Because administrative.
Defined by the board.
Right, it's defined by the board.
I mean, it requires it to be defined by the board.
I have map of workforce written down.
What?
Map of workforce, like around specialty type. I mean, primarily administrative. Is that the receptionist that answers the phone, or is that the CEO? Yes.
And I have written down, are the titles all similar across hospitals? So like what, is there gonna be something different for each one? And don't they already have the authority to ask for this information? I mean, can't they ask for anything in there?
That came up. There is a piece in this bill further along that sort of aligns the information that hospitals are giving to the board.
Yes, that's actually where we stopped.
Oh, I'm sorry. I should have.
Hospitals shall submit information as directed by the board in order to maximize hospital budget data standardization and allow the board to make direct comparisons of hospital expenses across the healthcare system.
Is there some way where we can take this 7 and tie it to 10B? That the board gets to define the categories of the information that they want, and that the hospitals have to submit it in that manner. I got Mari, I got Leslie, I got Woody. And then Lori.
My sense of what my own bill was Rep. Cole about executive compensation. And I think the Senate bill is pointing at executive administrative. So I'm first of all wondering if it would be helpful to have the word executive in there, to narrow down. And then there is the issue that, when Rep. Cole and I were working on our bill, ran into about there are, providers in a hospital who are providing direct patient services, but also have executive functions. And I know, I was trying to read this, the Baza statement quickly. I know that is a bit tricky to tease out, but we are looking at a much smaller group of people. So I think that that has to be manageable. I think we should still have, whether section 7 is in a different place or not, I still want to point, I do want to keep it in there, but narrow it to executive function. And keep it, have the board define it, but also they would have to have a conversation with the hospitals about how to make that happen.
Yeah, I think, which is, I'm wondering is if we should just leave it to the board, but tell the board kind of the direction. And then leave it to them to define it. Leslie?
Well, my understanding from one of our witnesses, the value of having that in there, even though one of the hospitals was fearful that it was redundant, was that if it's in statute, the board and the hospital is required to do it. So that it has value of keeping that in there. And that there is also value in the administrative versus clinical data to really understand the workforce if we're really thinking about going to some kind of regional coordinated care. So that we have an idea really of what the workforce looks like as it's distributed, and how do we then think about it from a regional point of view, which came out of Act 167 report, that we should think about regional planning. So I think it goes beyond just executive versus non-executive, even though I think that's important, really. I think that it goes more towards planning for the system.
Woody?
I realize the board has certain powers to ask for certain information, but I'll repeat what I've said in the past. This reminds me of Doge. I don't care for this section at all. I think it should be removed. I do like item B, where hospitals shall submit information as directed by the bill. I think it's getting into the weeds. And I think hospitals can manage their own personnel without having the board involved in that. Just a thought.
Lori?
I kind of agree with Woody.
Oh, wow.
I know.
Thanks. What's that part you don't like exactly?
I'm like, wait, hold on, let me
You
just.
spoiled it. I was about to say, I agree with Woody. She stole my thunder.
And I think, I understand probably the intent to get to it, but I just think there's like, even if just the fact of like trying to determine what one position is it the same thing at all 14 hospitals? It's why, like, I don't understand why we would make anyone go through that. And the board can, I agree with putting B in, right? Keep that information. So I don't know. I think we should take it out.
I was gonna say, I agree with Woody.
I'd be okay.
And I think we should leave it to the board what information the board wants. And that the hospitals are required to give the board the information that they want in the manner that they want it. I don't think it's up to us to decide what the board's gonna get in their hospital budget review. Isn't that the board?
I mean, it doesn't show here, but you do require them to submit a fair amount of information already in 1 through 6.
All right.
You don't see it because we're not changing.
That was my comment. Don't we already?
It doesn't mean you have to put this in or don't put this in, but I wouldn't not put it in because you don't tell the board what information to get because you do.
Thank you. Fair point. I always forget the ellipses.
Good terminology.
Topper? Oh, wait, do you want to finish your comment?
Yeah, I think we already asked the Green Mountain Care Board, the hospitals to provide information on executive compensation. And what we're getting at, what I thought we were getting at in number 7 is spending excessive executive compensation. That's dollars that Vermonters are paying for in healthcare dollars when there are many of us who think that that should go toward patient care. So that's the reason for at least our bill. And I would be okay with taking 7 out if we are truly asking the board or the hospitals to provide executive compensation information to the board in the hospital budget review. But I think we are.
Yeah, I think that, I mean, one of the things that's in the existing law that we'll get to in the board side of the budget review is that they consider the salaries for the hospital's executive and clinical leadership. And the bill would add, including variable payments and incentive plans. And then existing law again says, and the hospital salary spread, including a comparison of median salaries to the medians of northern New England states, and then some additional language added about comparing the base salaries and total compensation for the executive and clinic leadership with those of the hospital's lowest paid direct service employees.
Yeah, since we already got that, I should be okay taking 7 out.
I'm fine taking 7 out. Is everybody fine taking 7 out?
But I don't think it's dope.
I don't want to take it out, but I'm not, it's not gonna make me vote no on the whole bill if it gets taken out.
Yeah, I don't want to take it out either, but.
I'm willing to take it out if we put universal health care. We'll get there.
Section 5.
Yeah, we'll get there.
Does that mean we're taking 8 out too? Or no?
We take 8 out of universal health care.
I'm inclined to take 7 and 8 out. And thank you, Jen, for reminding us that we're in section 4, which is around the hospitals. And section 5 is the Green Mountain Care Board and what their authority is. So
I want to just look at what the.
Because this is the section of Title 18 that is regulating hospitals.
This is the sort of the hospital side of hospital budget review, what the hospital's duties are.
Okay,
And
thank
then
you.
the next section is the Green Mountain Care Board side of hospital budget review. And what they-
Okay, I see.
these are the duties of the hospital.
But only in regards to the budget.
Only regards to hospital budget review, yes.
Okay, thank you.
So are we taking 7 and 8 out?
I'm happy to take 7 and 8 out. Is anyone else?
You started.
Yes, and I'm gonna thinking whether I should push my luck here.
Can I push your luck? Can I ask you about 9?
Wait, before you get to
I'm sorry.
9,
Okay, sorry.
so I do also want to just flag a little bit that some of this, what you can't see, and the underlying 9454 has hospitals shall file. Number 2 is financial information, including costs of operation, revenues, assets, liabilities, fund balances, other income, rates, charges, units of service, and wage and salary data. So if the board wants more specific wage and salary data, especially as they're kind of going to be standardizing what the hospitals submit, they already have that specific authority, or there's a specific requirement around providing wage and salary data.
But this is a little different than wage and salary. It's about FTEs. and distribution.
Yeah, sorry, number 8 is really the base salaries and.
Yeah, I mean, it just seems like a different metric, but I guess I'm the only one that thinks.
I just think it goes more into, I think it's targeting people, honestly.
I'm not thinking, I mean,
Maureen?
I, one of the problems we run into with the current law is that is the 990s, the 2-year. So we want real-time information, not 2 years before. So I would want to make sure that we're getting real-time information, not the 2-year lag with the 990s.
What do you want? Yearly, you mean?
The information currently that the hospital has to provide,
Semi-yearly?
they don't have to give current information. They give information, salary information from 2 years prior.
But not in their hospital budget review that they submit to the Green Mountain Care
Yeah,
Board.
that's 2 years. In my experience, it's been the 2-year lag.
I think you may not be able to see the part, I think potentially within the confidential information, maybe the part that's more current than that. So I'm looking to the healthcare advocate and the hospitals, I think as part of what the board is actually looking at that is not public. They have more current information.
I don't know what part of it is public or not, but I do know that the board does ask for executive compensation. It's not forced to have that 990 lag, and hospitals are required to.
Okay, thank you.
And then compared to regional.
Okay. Thank you.
Okay, so we're all set on that?
Yep.
Good.
Okay.
Now,
So
I think I heard 7 and 8 are on the way. Okay, now I think you're now if you would like to.
I just want to make a statement. Somewhere along here, we're going to be talking about what we want the hospitals to do. And that's going to dictate the kind of workforce they have. So I just want us to keep that in the back of our mind as we go through, because we're talking about changing things.
Well, right now, we're talking about not adding more things to what hospitals already have to do in the hospital review process, which is already.
I get all of that. I completely understand that. All I'm saying is keep in the back of your mind as we go along in here. We're making changes and certain positions may not be needed.
Yep.
Because of those changes. So go ahead. That's all I wanted to say.
Okay, Leslie, and then I want to ask Woody about.
I just want to say I'm with you, Topper, because I think that we have to look at this regionalization kind of thinking. We may not need so much here unless we don't go, unless we have an understanding of staff and how that works. So I hear what you're all saying about not wanting to put more burden on hospitals on the one hand, but on the other, if we really want to move this transformation to a regional model, which was suggested in the Act 167, we need data to do it. And that's where I think this.
I think the distinction may be, though, that you don't necessarily need the data as part of the board's hospital budget review process. It may be important data to gather as part of the AHS and or Green Mountain Care Board hospital transformation work to understand where the workforce is now. But that's not the focus of the budget review. It's not the specific focus of the budget.
So is there something in statute that talks about the?
There's not, we don't have a whole lot on, hospital
no
transformation, what
guarantee.
that looks like. No, but we can certainly add it. I mean, this would be sort of the bill and the.
Yeah, that's what,
and
I'd like to be able to look at the system. I mean, we talked about a system. And until we look at it as a system, it also means the workforce as a system as well. So I just see that this is part of that. But I hear what you're saying.
and there may be opportunities to get information and, without putting in legislation, I'm looking at Kevin, because I don't know if Buzz would be able to provide information on positions that work, with hospitals or something, but just so that if they're interested in getting a sense of the existing workforce. I don't know if it has to be website or not. Sorry, didn't mean to put it in the.
I do know that and right out of my head, but the folks who are consulting for AHS have made payment requests and hospitals are providing them with data. Well, thank you.
Okay, can we move on to 9?
Yeah.
Guys, Woody, oh, wait, we crossed out 7 and 8. What, good morning?
I know you did, and I really do appreciate that. Again, I would like to see 10 and 10B, I mean, 10 real-time information. But I don't think it's necessary for 6 or 9. I think a lot of these things are already published in hospital end of year reports.
So wait, 6 is existing law,
Oh, okay, well, then I
Okay.
can't do anything.
Well,
about
which
it.
is why it's existing law, but it's why it's in the annual reports. So we know that because it's there.
Okay,
So
so,
I'm interested in your thoughts on 9.
but 9, I think, again, I think a lot of these things are promoted by the hospitals, at least mine is, in their end of year report, where they say, look at what your local hospital is doing for its community. And a lot of these things I think are published, at least in mine, and I don't. I would, and that's one reason. As far as the hospital duties go, I think Representative Topper is correct. We should be focusing on the duties related to what this bill is presenting, like reference-based pricing. What are the duties that a hospital has to do to comply with the Blue Mountain Care Board regarding reference-based pricing?
Does anyone have any thoughts around 9?
I will note that my notes say healthcare advocate would strike.
Well, no, I wouldn't cross out there.
No, he would strike the section.
Oh, you would?
I mean, 9, he would get rid of
That's great.
Sorry.
I'll buy you a cup of coffee.
Let's just all leave the room and have the.
Woody do it.
Be a healthcare advocate. Phew.
So I go back and forth. If we keep it in, this is like more harsh. They take down. I would get rid of proposals and say that they are required to report on how they are helping community-based services. And include, where they are in like actual measurable things they're doing. And at the same time, I don't think it should be on hospitals to support our community base. So I could go either way.
Who do you think it should be on?
I think it should be on everyone in the hospital service area, all providers. So, like services provided through the Blueprint for Health. How are and Choices for Care and SASH? I mean, I understand maybe if they have their own primary care system to make sure that they're pushing people to primary care before the ED. But I think it would be great if the system worked like this, but it doesn't. And to the healthcare advocates testimony, we've tried it.
I agree with you. I just want to know who you thought it should be. I think that the state has a responsibility here to support the providers and not dump it on any one player. That's my opinion.
Yeah.
But I wanted to hear yours first. Like, sounds like on the same page.
I would entertain an idea to strike this whole section. This is
Nine, you mean this
this whole, not the whole section, not section part.
It's like great.
This whole paragraph. For the life of me, I cannot figure out why in the hospital budget process, we would put, first of all, proposals is such I wrote squishy word next to it. But the hospital's charge is to serve the community as the community hospital. It's not the hospital's charge to support all this other stuff. And why on earth we would be tasking them in the hospital budget review process for what they're doing to help the community. I mean, frankly, that's on us. I would rather change it to the legislature should have proposals for the way they can support community based. I mean, I don't understand why it's the hospital's responsibility. And I mean, it's an advertisement. If they want to advertise all the wonderful things they do for the community, go and advertise it. But in the hospital review process, budget review, it seems extraneous. I'm sorry, go ahead. Leslie.
I was seeing this through the lens of global budget. So that the hospitals, do their global budgeting, and then what are they reinvesting in the community as a result of that? That may not be what was the intended here. And the language, I totally see taking out the specific references, but that was what I was wondering, that it came through that, the idea that.
I don't think so, but that's an interesting thought.
If they're on a global budget, then isn't their charge to deliver the healthcare services, the statewide allocation plan has set for that hospital within that confined budget to provide? And is it their responsibility for supporting all the other things that we don't fund appropriately?
No, yeah, I agree with that totally, but I think it's the idea of them being responsible for their population. And that through a global budget, they are reinvesting in their population. Now, it may not be through that model, I don't know, but that's how I was thinking about how the hospital supports the community. But it may not be community-based providers, I get that.
Brian?
So I was seeing it the same way you are. That I'm not saying I'm attached to this being here, but the only reason I could see why we would have this here would be if when the Green Mountain Care Board was reviewing a hospital's budget, one of the factors it was weighing is how much are they reinvesting? But this has proposals. So it's not like ways that we're reinvesting in the community. So I think that it's weird the way it's even worded.
Yeah.
And there's another way we can address this. But I was trying to understand why, and I think Leslie explained how I could see why, but why it would be in hospital budgets. It's like this bigger picture of reinvestment, like what are they gonna do with the money they get? But I don't think it needs to be in here.
So there's other things in here in consideration that the board in their hospital budget review can look at. Maybe we could add something around, because there's a piece in there about they should take into consideration their investments in primary care, mental health. Maybe it can be also in when they're reviewing hospital budgets, they will also take into consideration ways that the hospital is supporting their community,
Reinvesting in the community.
reinvesting in the community.
Yeah, I'll give a good example, if I may.
Mhm.
Brattleboro Memorial Hospital has a really wonderful program of using local EMTs to do pre-op visits prior to orthopedic type surgeries or CHF or, other kinds of things in the home. And this is really shortening recovery. Shortening recovery. People are getting better faster. And then there's follow-up afterwards. And it really is a reinvestment in the community that Brattleboro is doing. And it's a very cool thing.
So we could
So
take
that's
this
how-
concept and we could put it in that the board shall consider when reviewing hospital budgets, the ways in which a hospital is reinvesting in their community
Yeah.
and the system of care.
So my only question on that would just be sort of to what end, because they're supposed to take this information and establish a hospital budget. So what is the purpose of them considering?
Oh, I see what you're saying. I would say the purpose is like, why would the Green Mountain Care Board take that into account when I would say it's to maximize the benefits of the spending of dollars in the healthcare system, that if we're spending money on a hospital and the hospitals find creative ways to then spend money at promoting population health, then that's a smarter spending choice. So that's why I would think Green Mountain Care Board would want to consider that.
As a carrot.
Yeah, and just looking at ways how, like, sometimes $1 invested the right way can have triple the impact, and sometimes you put it in and it's like you lose $2 in terms of health. That's kind of why I would see it, but I don't know if my language is what you would put in a bill. It's just.
And it may not be the right place, sorry, but it may not be, but that's what struck me about it.
So at the top of page 11, in section 5, number 7, exclude revenue derived from primary care, mental health care, and substance use disorder. I have a may in there, by the way, but we'll get to that. But we could add an 8 of consider investments made in community-based providers or something like that.
There is already language, but no, about considering reviewing the hospital's investments in workforce development initiatives. So maybe if you're looking at their investments in workforce development, you could also have them review their investments in, community.
We could do that.
Just trying to figure out where, so sort of what you want them to do with that information. Are you wanting them to set a larger budget, just somewhat in tension with some of the other work in the bill?
Well, I think the intention would be that when approving and reviewing and approving hospital budgets, that there are outside considerations that may not just be costs and revenue. And that we want them to just keep that in mind. Murray, and then.
I guess I'm okay with just keep it in mind. I don't think we need section 9. I think the board can get access to that information already. And there's already language about that. And then just in principle, we've already gotten used to expecting hospitals to be all things to all people. And so this number 9 kind of rubs me the wrong way in this sense that are we asking them to just be a hospital and narrow their scope, or do we want them to be all things, to continue being all things to all people?
What is a hospital?
So I vote for removing section 9.
I vote for removing as well. Anybody else?
Be hospitals.
Yeah. Well, particularly if we're working on a hospital transformation and a statewide delivery plan, we're trying to right-size hospitals to deliver the types of care that we need hospitals to deliver. You're right. Why are we making hospitals be everything, everything to our entire system of care? And maybe that's one of the reasons that we've gotten to where we are is we've put way too much on hospitals. The topper.
As we go through the transformation, if you want to use that word, or structural change, the hospital will eventually be involved in that. I'm hoping that before we finish this thing, that we have a good outline of what we want to happen within the system that we're moving to. I don't think we need 9 here at all. I think we need it in another place where we're talking about the direction that we're going in to build the system.
Yeah.
And the hospital would be part of it. This may be appropriate in 29 or 28 or whenever we get to the point where we're regionalizing and the hospital is part of that regionalization.
But it's not part of the hospital budget review process.
No.
No,
I don't think so
I don't think so.
at this point.
Leslie, did you have something to add or?
I'm gonna only add, if I may.
Yes.
We've heard about status quo bias. We understand that hospitals do what hospitals do because of, how the system is designed. The pressure for hospitals to do something different is not very, they want to continue with, because that's what they know, it's their status quo. I'm not saying it should go here necessarily, but I think we have to acknowledge the need for some kind of nudging, I'll just say, to get hospitals to rethink their role in the community. I mean, yes, let hospitals be hospitals, but then we'll keep getting more of the same. And I'm worried about that.
Well,
I think we're doing it in different areas of the bill already.
Yeah, Topper.
you're right. Except that we're gonna do something about that, I hope, in this bill before it leaves here.
Okay, cool. I'm in.
I mean, well, that's why I'm in.
Yeah.
If that doesn't happen, I'm not in.
Brian,
It's quick, it's just that I think historically we've centered hospitals or not centered them. We've like created this hierarchy where they're at the top, and we've done the same thing with doctors, no offense to the medical society, but I think we need to move away from that the doctors and hospitals are at the top of the pyramid and view things more as a circle or a hub and spoke. I don't think this is the place that they're built to do it. And when we talk about like reforming the whole system, I would like for us to like this idea of centers of excellence, the idea of like hubs and spokes, but not that the hub's in charge. It's just a meeting point. And we'll get there. But I just want to add weight to what people are saying. I think there's another place in the bill we can get into this better.
okay. Let's finish up with
So
10.
9 is out.
Nine's out.
That's great.
It's spring
Let's
cleaning
just
today.
take page 9 and throw it away.
No, you got 10 on there.
10 is just such other information as the board may recall.
Yeah.
But you do, I think, there was significant interest in the Senate in subsection B, starting on line 17, requiring the hospitals to submit information as directed by the board to maximize hospital budget data standardization and allow the board to make direct comparisons of hospital expenses across the healthcare system.
That was,
There's money in the budget for that.
that was
In the
normally
HIT fund.
150,000 from the HIT fund to allow the board to facilitate this so that we're not putting the technological onus upon the hospitals. I'm thinking of this as one hospital submits their information on a 2,000 tab spreadsheet and the other one submits on the back of a cocktail napkin. And this is aligning so that they're all getting the same.
Yes, there's a program or system, I'm not gonna get the name of it, but adaptive, thank you.
And this,
I'm starting to think it's, that this would help, I believe, help the hospitals to all submit through.
And Dr. Liffle did support it.
yes. And this way the board doesn't have to weed through different mechanisms of getting different types of information. And they're all getting in the same thing. Is everybody supportive of this? Yeah.
That, and it's really, this is an area of frustration we've had for a long time.
If anybody would like to go to the Green Mountain Care Board's website where all the hospitals submit their budget stuff and you start thinking through all of the different hospitals' budget, it's impossible to align what you're even looking at. No more cocktail napkins.
Section 5 is the Green Mountain Care Board side of budget review. From the existing law and not changed here, it directs the board to conduct reviews of each hospital's proposed budget. And in conjunction with budget reviews, the board shall, and existing law has review utilization information. This would add in near the top of the list, consider the statewide healthcare delivery plan once established, including the total cost of care targets, and consult with the Agency of Human Services to ensure compliance with federal requirements regarding Medicare and Medicaid. I don't know if you want me to just go through these or if you want to take them one at a time.
Let's go. Does anyone have any questions around that thing? That piece?
Same.
So this is adding that they're considered that. Okay, so now we've moved on to the board's responsibilities around hospital budget review. This is what the board has to do. And we are putting right at the very top that they should it be, they consider?
They would consider the statewide healthcare delivery plan once established and consult with the Agency of Human Services to ensure
And so
there's
the
a federal requirement.
consider is, and it's shall, the board shall.
Yeah.
And everything thereafter is consider, so this is
For a
not
while, I mean,
profile. Murray,
Clarifying question, is Medicare in there because AHS manages the waivers?
I don't remember why Medicare is in there. Yes, I mean, probably to the extent it's a waiver that is allowing us to include Medicare.
Oh, Leslie?
So one of our experts talked about a iterative, continuous quality improvement process. Which I thought was an interesting thing to think about. Don't know if that would be required in the budget review, the Green Mountain Care Board. So that we would get a report each session, each session or each year, whatever, probably not each year, each session, to talk about what's been done, what continuous improvement processes have been done. Where instead of it, this seems like a one and done to me. And
This is every year.
where is that?
Well, it's the hospital budget review process. So this is what they're doing every single year.
Yeah, that's a budget process. That's not a continuous improvement process, which is a different ask of hospitals. And we may not want to do that, but that was
If
just
you're
one
gonna
of,
do it, I would take it out of the budget. I wouldn't put it in the budget review process.
then I would really like to have a thinking about it in the plan of how we do a continuous quality improvement process.
Yeah. And I think,
I have some language.
I would,
oh, you do?
Yeah, and we were gonna put it in different, I think in section 1, but it would be a start. Then we, Daisy and I worked on this with PQHC, with that acronym, right? Promote accountability and continuous quality improvement across the healthcare system through the use of data, scientifically grounded methods, and high-quality performance metrics to evaluate effectiveness and inform decision-making.
And I saw that and I appreciate it. I'm just wondering, does it go here or does it align more with
Section 1,
I'm thinking
I
maybe
think
more the
it's
plan,
the plan?
statewide healthcare delivery plan.
Yeah. I mean, I think a lot of it, like you said, in iterative, I think that's all sort of in the plan.
Right. What do you want your future healthcare system to look like?
And it needs to be evaluated on a continual basis, that it's not a one and done. To your point, Leslie. And then, once we get to the plan, because I think that plan is going to get fleshed out a lot. There's going to be a lot of additional stuff in there. But now all we're doing is in the hospital budget process, we're hearkening back to the plan that includes all these things. Does that make sense?
Okay, so the statewide plan is section 8, so
Yes.
application.
To me. Actually, we've gotten done more than I thought we would today, to be honest with you.
Third of the way through
We
the
are, we're on page 10.
30.
We are
That's all right.
10 of
Let's
30.
just say till we finish.
No.
I did want to ask, I was intending to go till 4:30. Is 4:30 okay for everyone? Do you all
4:20? Just
need,
kidding.
do you all need a break?
Yeah.
or a window.
I think we need like a break because it's hot in here.
Yeah.
Can we take a break?
Yep.
All
Right now?
right, let's go out. Yeah, right now, because I know you're.
Do we have window openers over there?
Okay, well,
It's
I'll
hot
take the
outside.
break right now, but one thing I want to make clear.
Okay.
Wait, is it related to the bill? Oh, we're live, still, we're live. We're still live, we're still live.
In this, the way it's worded now, do you feel that the hospital, can make short-term, changes in their budget? And, is there a stomach for a longer-term budget for a hospital instead of every 1 year? Keep that in mind.
Okay.
Mic drop.
Exactly.
You mean they wouldn't have a budget? They could not have a
It's like
budget.
Netflix. You have to wait for the next episode. Yes.